If you are over 65 and taking a statin, a cholesterol lowering medication, there are things happening inside your body right now that your doctor has almost certainly never explained to you. Not because your doctor is hiding anything deliberately, but because the full picture of what statins do, both the benefits and the specific risks that become significantly more serious after 65, requires a conversation that a 15-minute appointment simply does not allow. Statins save lives. I want to be completely clear about that from the very beginning. For adults with established cardiovascular disease, people who have already had a heart attack or stroke, the evidence for statins is strong and consistent. Do not stop taking your medication after watching this video. But here's what nobody is telling you. After 65, statins carry specific risks that become dramatically more significant than at younger ages. Risks that affect your muscles, your memory, your liver, and your blood sugar, and that most seniors are not monitoring for because nobody told them they should be. And there is a second secret that is even more significant. There are specific nutrients that statins directly deplete from your body, nutrients that are critical for heart health, muscle function, and brain health. And almost no senior taking a statin is replacing them. I have been practicing cardiology for over 22 years, and this is the conversation I wish I had time to have with every senior patient who walks through my door on a statin prescription. Tell me in the comments, are you currently taking a cholesterol medication? And has your doctor ever explained these risks to you? Type YES or no below. Before the secrets, you need to understand what statins actually do, because understanding the mechanism makes everything else make sense. Statins work by blocking an enzyme in your liver called HMG-CoA reductase. This enzyme is the primary driver of cholesterol production in your body. By blocking it, statins reduce the amount of cholesterol your liver manufactures, lowering the total amount circulating in your bloodstream. This reduction in circulating cholesterol, particularly LDL cholesterol, the form most associated with arterial plaque buildup, reduces the rate at which plaque deposits form inside your arterial walls. And this is why statins have been shown to reduce heart attack and stroke risk in people with established cardiovascular disease. The evidence for this benefit is real. A meta-analysis published in The Lancet examining data from over 170,000 patients found that every 1 millimole per liter reduction in LDL cholesterol produced by statin therapy was associated with a 22% reduction in major cardiovascular events. So statins work. The question is not whether they work. The question is, what else do they do? And what is the full picture that seniors over 65 deserve to understand before taking them for years or decades? Now let me walk you through what your doctor has not had time to fully explain. 4 specific things that every senior on a statin deserves to know. Secret 1. Statins deplete CoQ10. And this is serious. This is the most important and most consistently overlooked fact about statin therapy in seniors. And it is directly connected to the most common complaint I hear from statin patients: muscle pain, muscle weakness, and fatigue. Here is the biology. The same enzyme that statins block to reduce cholesterol, HMG-CoA reductase, is also the enzyme your body uses to produce a compound called coenzyme Q10, or CoQ10. CoQ10 is not optional. It is essential. It is the primary fuel molecule for your mitochondria, the energy-producing structures inside every cell in your body. Without adequate CoQ10, your cells, particularly your muscle cells, which have the highest energy demands of any tissue, cannot produce energy efficiently. When statins block HMG-CoA reductase, they block CoQ10 production alongside cholesterol production. A study published in the American Journal of Cardiology found that statin therapy reduced blood CoQ10 levels by an average of 40% within 30 days of starting treatment. 40% reduction in your primary cellular energy molecule in 30 days. This is the direct biological explanation for the muscle pain, muscle weakness, and profound fatigue that affect between 10 and 29% of statin users, with rates significantly higher in adults over 65 whose CoQ10 production was already declining with age before the statin further reduced it. But the CoQ10 depletion issue goes beyond muscle pain. Your heart is a muscle, the most metabolically demanding muscle in your body, beating 100,000 times per day. And your heart muscle cells are among those most severely affected by CoQ10 depletion. A study published in Biofactors found that heart failure patients on statin therapy who supplemented with CoQ10 showed significant improvements in cardiac function, exercise capacity, and quality of life compared to those who did not supplement. The recommended CoQ10 supplementation for adults over 65 on statin therapy is 100 to 200 milligrams per day of ubiquinol, the reduced, more bioavailable form of CoQ10. Not ubiquinone. Ubiquinol. The difference in absorption after 65 is significant. This is not alternative medicine. This is basic biochemistry. And it is a supplementation that I believe every senior on a statin should discuss with their physician. Secret 2. Statins and memory. The connection doctors rarely mention. In 2012, the United States Food and Drug Administration added a label warning to all statin medications, noting reports of cognitive impairment, memory loss, forgetfulness, confusion associated with statin use. This warning is on every statin package insert in America. Most seniors on statins have never read it, and most physicians do not proactively mention it. Here is the biology. Your brain is approximately 25% cholesterol by dry weight. Cholesterol is not just a cardiovascular risk factor, it is an essential structural component of every brain cell membrane. And it is the primary raw material from which your brain produces myelin, the insulating sheath that allows nerve signals to travel rapidly and efficiently. When statins significantly reduce cholesterol production, they can reduce the availability of cholesterol for normal brain function, particularly in seniors whose blood-brain barrier becomes more permeable with age, potentially allowing statin molecules to enter brain tissue more readily than in younger adults. The clinical presentation is subtle and easy to dismiss. A person on a statin begins experiencing episodes of memory lapses, forgetting words, losing track of conversations, feeling mentally foggy. These episodes are often attributed to normal aging or early dementia, but in some cases, they are a reversible side effect of statin therapy. A study published in JAMA Internal Medicine found that statin use was associated with a significantly higher risk of subjective cognitive complaints in adults over 65, and that these complaints frequently resolved when statin therapy was discontinued or the dose was reduced. I am not telling you to stop your statin. I am telling you to be aware of this potential connection. If you have noticed cognitive changes since starting statin therapy, mention this specifically to your physician. Not as a general complaint about memory, but as a specific question about whether your statin may be contributing. Secret 3. Statins raise blood sugar significantly. This is the secret that I find most alarming, particularly because of the enormous overlap between the populations taking statins and the populations at risk for diabetes. In 2012, the same year as the cognitive warning, the FDA also added a warning to all statins, noting that they increase the risk of elevated blood glucose and type 2 diabetes. The biology is specific. Statins reduce the sensitivity of muscle cells to insulin, the hormone responsible for driving glucose from the bloodstream into cells. When muscle cells become insulin resistant, glucose remains elevated in the bloodstream. Over time, this sustained elevation progresses toward prediabetes and eventually type 2 diabetes. A major meta-analysis published in The Lancet examined data from 13 statin trials involving over 91,000 patients and found that statin therapy was associated with a 9% increased risk of developing diabetes in seniors over 65, who are already at significantly higher baseline risk for diabetes than younger adults. This 9% relative increase translates to a meaningful absolute risk. And here is the deeply ironic clinical reality. Diabetes is itself a major cardiovascular risk factor, directly elevating the risk of heart attack and stroke. So for some seniors, statin therapy reduces cardiovascular risk through one pathway while simultaneously increasing it through another. This does not mean statins are net harmful. For most people with established cardiovascular disease, the cardiovascular benefit outweighs the diabetes risk. But it means that every senior on a statin should have their fasting blood glucose and HbA1c, the 3-month blood sugar average, tested regularly. And if these numbers are trending upwards since starting statin therapy, this specific association deserves a direct conversation with your physician. Secret 4. The cholesterol number your doctor is focused on may not be the most important one. For decades, cardiovascular risk assessment focused almost exclusively on total cholesterol and LDL cholesterol, the numbers that statins most directly reduce. But research over the last 20 years has increasingly shown that these numbers alone are incomplete predictors of cardiovascular risk, particularly in seniors over 65. The emerging understanding is that it is not how much LDL cholesterol you have that determines your risk. It is the size and density of your LDL particles. Small, dense LDL particles penetrate arterial walls much more easily than large, buoyant LDL particles, making them significantly more atherogenic, more capable of forming dangerous plaque per unit of measured LDL. Two people with identical LDL cholesterol numbers can have dramatically different cardiovascular risk based on their LDL particle size. And statins, while they lower LDL cholesterol consistently, have variable effects on LDL particle size. Some statins improve particle size favorably. Others have minimal effect. There is also a measurement called ApoB, apolipoprotein B, which directly counts the number of atherogenic particles in the blood rather than estimating their cholesterol content. Many cardiovascular researchers now consider ApoB to be a more accurate predictor of cardiovascular risk than LDL cholesterol alone. Most seniors have their LDL measured routinely. Very few have their LDL particle size or ApoB measured because these are not standard components of routine lipid panels. If you are on a statin and your LDL number appears well controlled, but you or your physician remain concerned about cardiovascular risk, ask specifically about LDL particle size testing or ApoB measurement. These tests provide a more complete picture of your actual cardiovascular risk than LDL alone. Now, let me give you the concrete steps that every senior on a statin should take to maximize the benefits and minimize the risks. Protection step 1. Supplement CoQ10 ubiquinol daily. 100 to 200 milligrams of ubiquinol, not ubiquinone, taken with a fat-containing meal daily. This directly replaces the KQ10 that your statin is depleting. If you have been experiencing muscle pain, muscle weakness, or unusual fatigue since starting your statin, discuss KQ10 supplementation with your physician before any other intervention. Protection step 2. Monitor blood sugar every 6 months. Ask your physician to include fasting glucose and HbA1c in your blood work every 6 months while on statin therapy. Track these numbers over time. If they are trending upward, even within the normal range, this trend deserves discussion before it crosses into prediabetes or diabetes territory. Protection step 3. Monitor liver enzymes annually. Statins are processed by the liver and can, in some cases, cause liver enzyme elevation, a sign of liver stress. Routine liver function testing annually while on statin therapy is standard of care, but it is frequently omitted in busy primary care settings. Ask specifically for ALT and AST to be included in your annual blood work. Protection step 4. Report muscle pain promptly. Any new or worsening muscle pain, weakness, or tenderness that develops after starting or changing statin therapy should be reported to your physician promptly, not endured. A rare but serious statin complication called rhabdomyolysis involves the breakdown of muscle tissue and can cause kidney damage. Early reporting of muscle symptoms allows your physician to assess whether dose adjustment or medication change is needed before serious damage occurs. Protection step 5. Ask about statin alternatives, if appropriate. Statins are not the only option for cholesterol management. For seniors with borderline cardiovascular risk, particularly those who have not had a heart attack or stroke, the risk-benefit calculation of statin therapy is more nuanced than for high-risk patients. Ask your physician specifically whether your current cardiovascular risk profile justifies statin therapy or whether dietary, lifestyle, or alternative medication approaches might provide adequate protection with fewer side effects for your specific situation. Your action plan. 5 steps starting this week. Action step 1. This week, check whether your current blood work includes fasting glucose, HbA1c, and liver enzymes ALT and AST. If any of these are missing from your recent results, request them at your next appointment. Action step 2. Speak with your physician or pharmacist about CoQ10 ubiquinol supplementation. If you have been experiencing muscle pain, fatigue, or weakness, mention this specifically and ask whether it could be statin-related and whether CoQ10 supplementation is appropriate for you. Action step 3. If you have noticed any cognitive changes since starting statin therapy, memory lapses, mental fog, confusion, mention this specifically to your physician as a potential medication side effect rather than simply a general cognitive complaint. Action step 4. Ask your physician at your next appointment whether your cardiovascular risk profile justifies your current statin dose. Risk profiles change with age. A dose that was appropriate at 60 may be higher than necessary at 72. Action step 5. Share this video with every senior in your life on cholesterol medication because they deserve this information. And they are almost certainly not getting it in a 15-minute appointment. Statins are among the most prescribed medications in the world. And for the right patient in the right clinical situation, they provide genuine cardiovascular protection. But medicine is not one size fits all. And after 65, when CoQ10 production is already declining, when cognitive vulnerability is already increasing, when blood sugar regulation is already less reliable, the full picture of statin therapy deserves more than a prescription renewal without conversation. You deserve to know about CoQ10 depletion. You deserve to know about the cognitive warning. You deserve to know about the blood sugar risk. And you deserve to have an informed conversation with your physician about whether your specific statin regimen is optimally calibrated for the body you have at 65, 70, or beyond. Knowledge is not a reason to stop your medication. It is a reason to manage it better. If this video gave you information that changes how you manage your health, please subscribe to this channel. Every week I bring you senior-specific, clinically grounded, genuinely useful health information. Hit the like button if this surprised you. Leave a comment. Did you know about CoQ10 depletion before watching today? I want to know. Thank you for watching. Take your medication wisely and take care of yourself because you deserve complete information about everything that goes into your body.